Welcome, everyone, to another exciting version of Chip Talks podcast. So today we're very honored and privileged to have Dr. Shah with us. And Dr. Shah is a practicing physician in India. She runs clinics in India, which we're going to talk about. But I thought it would be interesting for you guys to hear a little bit about how medicine is practiced in other parts of the world. And certainly in a part of the world that really values nature, and the ability of nature to kind of help and heal us, and has an ancient tradition of all that. So welcome, Dr. Shah. It's an honor to have you on the program today.
Thank you. It's great to be here, and I'd love to have this conversation today.
Very excited to have it with you. So do you want to just start off and tell us a little bit about kind of your field of medical specialty, and then what you do day to day in your clinics in India?
Perfect. So I'm a preventive cardiologist. So I'm also a health coach. I'm an integrative health coach through Duke University in the US. And so I work on a preventive aspect, preventing lifestyle disease, preventing heart disease, especially. We try and not go to the point where we need stents and bypasses. So we do a cardiovascular risk assessment. We look at all your figures, and we look at, getting that hypertension in check, your cholesterol in check. We'll do all the tests and start with the lifestyle changes really, and then medicate where necessary. But I believe more in a preventive approach, which is why I go into coaching as well. So if you can, check that lipid, your LDL in check with just your exercise and diet, then that is what I start off with. And then, if it's not happening, then obviously we prescribe the medicine when necessary, because they have their place, of course. But a lot is to do with your lifestyle. So I like to play with that. And then that's where I tie my coaching in. And I help them, transform their health, transform their lives through health coaching.
Would you say, like, just underlying, comorbidities or morbidities or whatever that happen with heart, would you say that, obesity and some type of infection, be that a pathogen or some kind of chronic, inflammation, are those the two biggest things that you see that are kind of associated with heart disease, or are there others?
There's a lot. So one is obesity. The biggest cause is actually smoking, because smoking increases your risk by almost tenfold. So that is the biggest cause. There is diabetes, and there is hypertension. I think these are the three biggest. And then there is obesity. There is high CRP, which is an indicative marker for inflammation of any kind. And there are so many others. You look at LDL, you look at LPA, which is a genetic factor. You look at, your abdominal girth, especially visceral fat. All of these play a role in increasing your heart disease risk. So we try to look at all of these parameters and then work what is not okay, and try to get that back to the right levels, essentially.
And are most of your when you're talking to your patients, do you talk to them about fasting and fed? I guess is a big thing, because it's, it seems like most people here in the United States don't. I talk about fasting and fed all the time. Even PhDs and well-trained people just look at me like I'm a crazy man. So do you talk about fasting and fed in India?
Yeah, I do actually. So a lot of people do intermittent fasting here. It's become like a trend, like keto became a trend, like gluten-free is a trend. It's almost like a trend now where a lot of people are intermittent fasting, but it does a lot for your health. So for people if it suits them, I do suggest that they try it, because I think that it's really helpful with your glucose, with your insulin spikes. It really helps calm all of that down. Reduces your risk of insulin sensitivity and subsequently diabetes.
Do you see is it a dramatic difference in your patients who will intermittent fast and their outcomes versus those that won't?
So it depends. I think every body is very different. So I think, but I definitely find a change with, the diabetes numbers when people actually do it. Because a lot of times people don't do all that you tell them to do when you're a doctor, so that is a challenge. So it's very difficult to sort of narrow it down. But I do see a change when people really align with what they need to do. there is a change with numbers. There is a change with the way you lose weight because your glycogen is stored in your fed state and your glycogen is broken down in your fasted state. So rapidly lose weight compared to when you're eating normally.
Yeah, and the other interesting thing that happens too, which I know we're going to talk about in a second, because you're also very interested in women's health. But when you're in a fed state, I kind of fasted, fed, use the mitochondrial, glucose down here, fat down here. But when you're in a fed state, you're making cholesterol, and as cholesterol is the precursor for all of our hormones, right? So we're kind of making all the hormones that we need when we're in a fed state. But when we're in a fasted state, we're catabolizing them or breaking them down. So we're making estrogen and testosterone and all that up here. Do you see that in your, I'll hold that question until we talk about women's health. So just sorry, I got ahead of myself a little bit, because I really want to see if that makes a difference in the hormones and things that you're seeing in women's therapy. So do you want to go ahead and answer that now, and we'll come back to women's therapy?
Sure, I definitely think it does. I think when you're actually in that fasted state, your hormones are, more regulated, I would say. They're not shooting up and down, and they're not going as crazy as they would when you're just eating normally and you're constantly in that fed state. And even your insulin you're not giving it a chance to kind of settle down, and the glucose to plateau down, and it just keeps spiking up is what is happening even with the glucose. It happens with the FSH. Already when women are over 40, your FSH is going high, because it's stimulating your ovaries to, ovulate, and because you're kind of going through menopause, and that's not happening. And your FSH is going up, and that has so many repercussions to, increasing your risk for so many diseases, osteoporosis, a lot of things.
Yeah, no, that's really cool. And it's, I think it's fascinating. In the US, it just, no one is really, there might be a handful, but no one that I know about really that has a clinic situation that's, a MD, but that's talking about like nutrition and lifestyle. And, there's a lot of that stuff that gets kicked around, but nobody's really focusing on that. Do you also focus on diet? Do you focus on kind of, as you're talking about intermittent fasting, you say, hey, you kind of need to be eating in this box? Do you talk about diet as well?
Yeah, so you try to eat in those 6 hours and then you fast the rest of the time. But also the quality of the diet is very important. It should align with heart healthy diet, specifically for me, since those are the patients I deal with. I like to follow the DASH diet with my patients, or I ask them to use the Mediterranean diet. Because unless you're eating traditional Indian food, so there is a whole host of different people in India. We have some that are very traditional minded who eat Indian food every day. Of course, not the curries that you'd see in the restaurants, but healthier versions of those. And then there are people who eat salads and soups and all of that. So for patients like those, I specifically prescribe like a Mediterranean diet. And you sort of use the same nutritional concepts and convert them to Indian food for patients that want to eat more Indian.
Are you finding that, omega-3 and omega-6, balance the importance of that, and kind of, I don't know how it is in India. I think it's the same as it is in the US, but in the US here, so there are lots of research that says if I eat 1-to-1 omega-3 and omega-6, or 1-to-4 omega-3 to omega-6, that you can't kill me. You can't get me sick. I have a banging good heart. I'm going to be really, really strong. Let's say if that ratio goes up to around 1-to-20, I'm sick. I get cancer. I have autoimmunes. I can't maintain a barrier in my blood-brain barrier even. So all kinds of things go wrong. We're about 1-to-40 right now in the United States. I think India is similar. Do you see that heavy omega-6, like let's say in diet related to heart disease?
Yeah, definitely. I think there's more of omega-6, even more of saturated fats when it comes to heart disease, people eating a lot of fried foods, things like that. The omega-3 is lacking because, especially in, I would say, the north or the west, coastal regions, I would say it's better because they eat fish. So as soon as you get the omega-3 from the fish, even if they don't have supplements, their omega-3 is generally better than people living interior or areas where they don't have the sea or access to the ocean. as much because they tend to eat less unless they're very conscious of it. And those are the very healthy and conscious people, but that isn't the larger demographic, really.
Yeah, it's really interesting, how the endocannabinoid system works, and it's doesn't really, and that's what I study, and it doesn't, everybody thinks, oh, it works with, marijuana. No, it works with dietary fats, which is really cool. And so omega-3 is such a huge thing in the system. Oh my gosh. And it's so gone, from our diet, right? It's like, name me 6 sources of omega-3, ready, go. And, oh, what?
Hard. Yeah, it's really hard. Yeah.
Yeah. So, chia seeds and, hemp seeds and walnuts are, good sources. But, those are kind of hard to find. So I talk a lot about the importance of omega-3 because of this ratio. And, I know kind of the importance, and we program ourselves literally by this ratio of omega-3 to omega-6. You kind of set how your spring is going to unwind, whether it's going to be inflammatory or if it's going to be anti-inflammatory. And then you set the sensitivity of your spring by that O3-O6 balance. So it's very good that a lot of physicians, let's say, aren't even, what, omega-3 fats? We need those. So they're not even those.
They don't even prescribe them. Yeah.
Oh, and you prescribe them. Cool. Do you prescribe, are you looking at DHA and EPA, or are you looking more at the alpha linolenic acid? And you may not know, but it's like when you prescribe alpha linolenic is the top line omega-3, and then it's broken down into DHA and EPA, and that's sex difference, which is, yeah. So, yeah.
I do. Yeah.
Cool.
Because
Okay.
omega-3 to do with it is a huge it helps reduction in heart disease risk. So eating your omega-3 is actually very important, either through your diet, if you can get it through fish or avocados or flax seeds, things like that. But otherwise, definitely a supplement is, I always prescribe supplements to my patients, especially when they're vegetarian, because a lot of Indians are vegetarian, and so they don't get their omega-3s very easily and not as accessible. So I always prescribe that.
Very cool. No, I think that's one of the most important things you can do for your heart is, in almost anything is it just helps. Omega-3s are going to help everything because we're so omega-3 deficient. So it's awesome. Cool. So you also study women's health, right? Which is I think so many women suffer in silence with, things like endometriosis, hormone, things where they're, trying as hard as they can to kind of control emotion, and they, have difficulty because of hormones, and they just sort of quietly plug along. I think we really need to highlight, at least here in the US, more women's issues. Do you want to talk a little bit about what you do there and kind of why you're passionate about that?
Yeah, because I think that a lot of challenges that women face, they put on all that weight, when you hit menopause, they suddenly, although they do their yoga and they exercise, they suddenly put on that weight. And it's especially, I find, for women who are regular with their exercise and who are very fit, and suddenly they're having this issue. A lot of it is self-esteem issues and health issues. They have their, hot flushes, increased risk of so many diseases, and they get, depression, anxiety. And so I'm very passionate about it because I see so many women going through this. And as a woman, I, can relate to it, I think, in some way.
It's interesting. Something that I find, and again, I'm not a doctor, but we consult, let's say, with, customers about their health. So I can't say any of the medical words or I'll get myself in trouble, but we help, let's say, with all different kinds of things. And one of the things that we see is a lot of, let's say, pathogen, infection in people. And we use a tool called bioresonance, which is a frequency tool, which is kind of interesting. And it's not a medical device by any means. It's kind of an informational thing, but it's really good at identifying pathogens, which is cool. So we see a lot of pathogens in people. And interestingly, I'm just interested in what you think about this, but in a lot of women will come in and women will say, hey, I'm having hot flashes. I think I'm going through menopause. And it's every night, this kind of happens. I get the sweats and everything. It's worse when I cycle, absolutely. But, it's every night and it's worse when I cycle. Like, okay, well, that's interesting. Maybe you're going through menopause. But as I begin to research this, there's so many pathogens that they use something called LPS, which is used in research that causes inflammation to kind of move around in your lymphatic and your blood system, which will make you hot. So there's so many pathogens that will travel at night and kind of use these heat releasing, molecules to do this travel. So I'm like, I wonder if all these women are actually just, kind of chronically infected. What do you think about that?
I think it's very interesting. I think there should be more research on this, obviously, but from a medical perspective, because they don't teach you this in traditional medical school when you go to medical school. So it's very interesting to see because, if you delve deeper and to a more microbial level, I think these could be some of the reasons, at least, that women are facing hot flashes, or at least maybe something would, be affecting the hormones maybe, or I don't know the metabolics at play because these pathogens need to be studied more, but this could be very fascinating.
Let me walk you through something because I want to kind of get your opinion on it. And this is just logic. It's I'm not going to put you on the spot or anything. So just logic. But and because I see this so much, and I see this in people that we're diagnosing. And the reason that I want to kind of walk you through this is because in medical science right now, you guys don't have like this bioresonance thing you would never see in a hospital, right? So there's no way that, it's just not getting in there. It's not getting in any clinics, because no professional medical person is going to kind of use this woo-hoo-y thing to, diagnose people. So it is good information, no question, but it doesn't rise to the level of an instrument, let's say, that a physician would use. So the tools that you have right now are limited, right? So if I come in and say, hey doc, I think I have a hook, round, and pinworm infection, you're going to be testing my poop, and I'm gonna have to rise to a certain level, let's say, of angst to even register, on the radar, and you're not going to do that in the course of common practice. Certainly not for heart patients. So let me walk you through something real quick. I'll do this real quick, but you get infected by a hook, round, or pinworm, right? So in order for that infection to take place, those hook, round, and pinworms have to beat your immune system. That takes a trick. That's difficult, right? So it's hard to do. It's easier to do if you're always fed. Way easier to do. Okay. So just FYI, but so if you're always fed, they're going to get you and they're going to win, right? So, and they're going to win, they're going to begin to proliferate. And this happens even if you are in a fasted state, they're very powerful. You're going to have a better chance of defeating them if you're in a fasted state, right? But anyway, as but as they infect you, so right off the bat, they suck your blood, so you begin to get anemic. The second thing that happens is, as they, again, are infecting you, you're building immune mediators, and those immune mediators happen in bone. So they come from our bone, right? Stem cells in bone. And there's a turnover rate we can handle there. But if the infection rate gets bad enough, now we're having some bone loss, right? So second thing that begins to happen is bone loss. The next thing that happens is, again, all this stuff is traveling around in blood, all these immune mediators. So blood begins to thicken. So we begin to have some high blood pressure. Then the next thing that happens is, gosh, we're filtering all that junk through our kidneys. So our kidneys begin to go, I'm tired. Glomerulonephritis. And, so all these, diabetic markers, right? And all this, I don't have diabetes. I've just got a hook, round, and pinworm infection, but I look like I've got diabetes. And then the last thing that happens is the heart, right? So it's easy to move thin hydraulic fluid. The thicker that
that much more pressure, right? Exactly.
So what do you think of that?
So I think it's very fascinating because you get it once the infection gets into your blood. I think then it travels to different parts of your bodies, like you said, probably nephritis, and as soon as it reaches the heart, the thick fluid. And the heart has to pump so much more with so much more energy. So one thing is your BP shoots up. There would be endocarditis. Your heart will get inflamed. Your ventricles particularly, because that's doing the pumping for the rest of the body. would get really inflamed and, increased in size, and then there's cardiac insufficiency, and then, it can go anywhere, really.
Yeah.
You can have a myocardial infarction, anything.
I completely agree with you. So it's always this thing when somebody says, oh, well, Joe died of a heart attack. In my mind, I'm like saying, no, Joe likely died of some chronic inflammation that caused a heart attack, because God is a perfect engineer, right? He built us all perfect, and everything in us is always striving toward perfect health. So if we're doing this, there's a reason, right? There's got to be something. It's not we're just broken. God didn't just say, Chip, you're going to have a heart attack today. It's likely I did something to cause an infection that caused situations that increase the likelihood of that. Yeah, cool. So what do you really, in 5 years, what do you see yourself doing?
Well, I see. So I'm taking my coaching forward as well. So I see, I would still want to do a mix of it. I would want to practice my medicine with my coaching. But I see myself coaching people globally, really, on preventing lifestyle disease and reducing the risk for heart disease, maybe, and even other lifestyle diseases, and helping them get happier, fitter, healthier, and really working with so many different people, making a difference to their lives. And that is what I look at doing.
Very cool. Where do you think medicine will be in 5 years? Do you think medicine will be more open, let's say, and more inclusive of lifestyle and, let's say, natural products and kind of nature than it is now?
I hope so. Yeah. I hope so. There's definitely postgraduate courses in the US on lifestyle medicine and things like that. It hasn't reached India as yet, but I hope that is a change. And also with the natural products and things, I hope that there is more integration with nutrition. Because it's very funny, as a doctor, we don't learn nutrition in medical school. There was probably a 1-hour class in 5 years on nutrition, and they don't teach you that you can prevent all of this by eating right and exercising right. They don't teach you that. They teach you how to stop things with medicine. And I think that is where we need to change.
Mm-hmm. Completely agree with you. And you said that beautifully. And most physicians, and for you guys, out there, most physicians get 1 hour of nutritional training in their complete, PhD level training. How many hours did you get on the endocannabinoid system, which has nothing to do with marijuana?
Zero.
Yeah. Zero. Yeah. And it turns out that system is our master regulatory system. Exactly. It sits in function above the central nervous system. So it's a pretty important system to study. But it's interesting. I think I agree with you. I think medicine is changing. I think people like you are changing it. And I want to compliment you on your bravery. It's when you step out of, let's say, the box, the medicine kind of pharmaceutical box, and really dealing with lifestyle, you're stepping out of the box. You got an hour of training on it, right? So you're stepping out of the box, and you're saying, this is better. This is different than the, let's say, standard. And in the past, that has been sometimes a difficult path. Sometimes, your fellow physicians will demonize you. The medical system will demonize you. Have you had any of that happen to you, or have you been well supported in what you were doing?
No, it has happened, because it definitely takes courage, and a lot of people don't believe in it, or it's something very new. So there's two things. There's a lot of intrigue, I would say. A lot of people are very intrigued with what I do. But with doctors and things like that, I feel like senior physicians, and they find it hard to accept that we're not doing the traditional, path, especially because I come from a family of doctors. My parents are doctors, my grandparents are doctors. So even there is a, I'm treading off the known path and into a little bit of an unknown zone, essentially. So it's fun, it's new, it's interesting, it interests me, so I'm happy doing it. But there are these two things, I think.
Is your family, being physicians, is your family supportive of your path? I mean, are they open-minded? Are they? Yeah.
Yeah, they are.
Oh, that's really cool. So I'm a theorist, right? So I'm always, coming up with wild, crazy ideas, and I have a lot of grant ideas. And so one thing that we might talk about in the future, since you have a, I'm always looking for clinical situations and, kind of partners on grants to, look at different things. So you would be a cool partner on any kind of, heart type lifestyle, type research. So that's really cool that you're doing this. And
very interesting.
yeah. And then the other thing that, you might look at expanding your model to the US. No one's really doing, what you're doing in the US. So all you guys out there with money, you might talk to Dr. Shah about doing something like this here in the US. And there's a real need for I would say, lifestyle, alternative kind of testing, clinic, type thing in the United States. People are really asking for that now. And I really hear that, in what we're doing. And that's why, we have the business we have. So that's cool. Okay. Well, is there anything else that you want to get in and talk about a little bit? I think this has been a fascinating discussion.
What would be, I'm open to this conversation. So what would you like to talk about? We can talk a little bit about preventive cardiology and, how you can prevent heart disease or lifestyle disease.
Yeah, so
we can also talk about neuroscience habit change. So wherever you'd like to go with this.
Yeah, so let's talk a little bit about, so what would be your main, kind of standard, let's say I come into your clinic, I'm a little bit overweight, I've got some heart issues. What would kind of be your standard, let's say, protocol for somebody like me as I left?
So I think as you come in, the first thing I would do is have a interview with you. Obviously, I would sit down, ask you your symptoms, I'd ask for blood tests if you don't already have them. A lot of patients come with their blood tests. So depending on your symptoms, I would ask for a list of blood tests. Common things like, of course, your HbA, hemoglobin, things like that. But also a lot of cardiovascular risk markers, your CRP, all of these things. I do a lot of lipidology. So I'd like to do a lipid study. So obviously your LDL, VLDL, and HDL. But also things like LPA, apolipoprotein AB, because all of these are risk factors then and add to your risk of cholesterol and subsequently heart disease. And I would then obviously prescribe or at least prescribe lifestyle changes initially, depending on the blood test and blood results. And, then go from there. I do your blood pressure check and all of these things. We do a whole cardiovascular risk assessment. I also use the JDL score, those kind of scores online that you have these calculators and they calculate your 10-year heart disease risk. So they essentially tell you what percentage or how likely you are to have a heart event in 10 years, depending on various factors from whether you have diabetes, whether you have hypertension, cholesterol, whether you smoke, your weight, your BMI. So all of these things play a role in that.
I don't know right off the top of my head because I haven't studied actually the, let's say, cellular mechanisms of the heart that deeply. We've studied other things very deeply, but does the heart, is it beta oxidizing in how it's producing energy, or is it a glucose? Is it a glucose, or does it depend on fasting and fed?
It depends on fasting and fed again. Yeah.
Okay. So if let's say you're in a fed state a lot, I mean, that's going to cause you to be operating your heart on glucose. That's less efficient, right? So it's, 30, 50 times less efficient. So I definitely want to be operating my heart on fat. But when you're operating your heart on glucose, is that when you see the buildup of like, these lipo-A?
Yeah, absolutely. Yeah, that's what happens. And when you're in the fasted state, you're even using that visceral fat or even cutting down that cholesterol, you're using it as energy and you're not storing it, because you're storing everything when you're in the fed state and you're not when you're in the fasted state. So you tend to collect all that cholesterol when you're in the fed state.
Yeah. And so isn't that interesting, though, that really what we're measuring as heart risk is, eating behavior.
Yeah, exactly. Yeah.
That's what we're doing, so how do you, decrease your heart risk? Well, fast is a good way to do it. That's fascinating to me. That's really cool. Do you see like, so, and again, I just sort of, I'm talking out loud here, but on fasting and fed, because in this beta oxidizing versus glucose, because I think this is so important. And the heart, you know, arguably is our biggest, you know, most important thing in our entire body. I mean, you can't function without the heart, right? So operating that efficiently, is just, you know, we have to do that. So this is interesting. So I learned something on this. So it's fascinating. Cool. So do you see, do you measure ketone activity in the heart? Is that ever measured?
That is measured specifically in certain situations, but not always. That is in the protocol.
Okay.
It could be, but we could do a little bit more research there. But this isn't the usual protocol that you would normally follow in a patient when you, at least initially, look at them.
Yeah, no, there's probably all kinds of opportunity for interesting tests there. You know, so that's got my mind whirling now.
Yeah, this is interesting.
Yeah. No, that's so cool. And it, you know, I think people like you will begin to, you know, the pharmaceutical system has, well, you know, to kind of run you guys down this real quick, and I know you likely know this, Dr. Shah, but the pharmaceutical system was built, the pharmaceutical medical system was built around something called the Flexner Report. And the Flexner Report was, you know, a way to, let's say, combine medical curriculum, you know, lab studies, pharmaceutical drug development, kind of into one line of thought. And that happened in the 20s and 30s. If you were Dr. Shah in the 20s or 30s, you got beat into submission, or you were cast out and bankrupt, you know, in lawsuits, right?
Absolutely.
Yeah, they forced everybody into a model. So it's so cool that we have to break that Flexner, let's say, model. And people like you are doing that. So it's, you know, it's amazing that you're doing that, which is really cool, and kind of stepping outside of your training. And, you know, just this discussion that we're having about the heart is a discussion that likely we couldn't have had 15 years ago. You know, the pharmaceutical industry wouldn't let us have it. So it's really cool, and I'm so glad you're talking about fasting and fed, and you know its importance directly to the heart. Okay, what else do we need to get in? So this is kind of a good place likely to leave it. If you want to leave it here, if we want to talk about a few other things, we can.
I'm good to leave it as well, whatever you say.
Yeah, so let's do, this is a great place, and let's have you back on in the future. So you're a great guest, and I want to kind of get updates. I want to, I know that India is very closed right now to, let's say, some of the things that, you know, people in my audience are interested in. And I'm interested to, there's a lot of research, let's say, on the endocannabinoid system and angina and plaque and, you know, all kinds of, let's say, heart risk. But as that develops, I want to kind of have you back on and talk more and more about that. So
I think it'll be very interesting as, you know, that information comes here and laws may be changed with marijuana story or anything like that, because they don't talk about the system here at all. So maybe once they start teaching that, or at least there is more information around this, I think it would be interesting to see how things develop and change.
It's a, you know, it would be interesting, and I don't know how popular this would be, but there's a peer-reviewed medical journal called the American Journal of Endocannabinoid Medicine that's targeted at physicians, and it would be interesting.
It would be interesting to see.
Yeah, if we could penetrate, you know, India kind of with that, and at least because it really has nothing to do with marijuana, right? So, but everybody goes right to marijuana.
Here's the word. Yeah, it's the word that goes.
Yeah, I know. Yeah. I literally speak on it, you know, be speaking to a bunch of PhDs. I'll say endocannabinoid. I watch them all just go, you know, marijuana, and it's really got nothing to do with marijuana.
Yeah.
Okay, well, cool. Well, thank you so much for being on today. I'm so excited to have you.
Great. It was very interesting.
Cool. No, great for me too. So we will leave it there, and